We know that TAVR outcomes are frequently as good or better than SAVR outcomes. However, little population-based data, particularly from like an entire region, are available. And so we're here to discuss a paper from JACC Interventions, Utilization and 1-Year Mortality for TAVR and SAVR in New York patients with aortic stenosis, 2011 to 2012. And I am with one of the authors, Dr. Craig R. Smith, MD, who is chair of the Department of Surgery and Surgeon-in-Chief at NewYork-Presbyterian Hospital, Columbia University Medical Center. First off, welcome. Why did you do this study? This is interesting.
Well, we were interested in what it would look like in a statewide experience. All comers on the surgery side, all surgeons, all centers, and on the TAVR side, at that point, kind of early adoption, meaning more than just one trial center. So
right.
It was a period in time when TAVR numbers were really starting to take off and more than in one pair of hands.
And this is actually data from the New York Cardiac Surgery Reporting System.
Correct.
Can you just remind us what that is?
Well, that is actually the original statewide database. It goes back 20 plus years now and has been kind of meticulously groomed over the years to refine the risk adjustment methodology, and is the original reporting card system, if you want to call it that, where going back 20 plus years, surgeon results and hospital results were available to the public, which has been very controversial, but I must say less of a thing than you might imagine.
I was just going to say, after 20 years, one would hope that it's less controversial now than it was.
Mm-hmm. Certainly in New York, it's less controversial. At least we've all gotten used to it.
Right.
And I've been asked many times to comment on how can this happen. And in the UK, for example, a few years ago, when they started having a surge of interest in public reporting, I was asked to do a pro and con editorial on the subject. So this comes up pretty frequently, and I think people tend to overestimate the negative impacts. They don't underestimate the benefits of having results out there, but I think they overestimate the negative impacts.
So in this particular analysis, how many patients' data were you using?
Well, it was a 2-year collection, so it's thousands of patients. I've forgotten exactly the totals. I think the TAVR patients were 1,000 plus in that neighborhood. So decent numbers.
I found an interesting thing from your exclusion criteria. You excluded patients who were 95 years of age or older, 44 of whom underwent SAVR and 40 of whom underwent TAVR. This is 95 plus.
Yes.
That was pretty impressive. I learned that from your exclusion criteria, so the rest of the paper must be really good.
Yes, well, those patients are still treated in both categories. I think the oldest TAVR patient that we treated at Columbia was 100.
Wow.
So there are people like that, but as the exclusion numbers show you, 40 here and 40 there, not many of them.
True.
But
they are undergoing.
And in the pre-TAVR days, we did operate on people in their early to mid-90s with some frequency.
So what did you find in this analysis? What did you learn?
Well, I think we learned the most important thing, since the results in the two groups were pretty similar, and there weren't probably enough numbers to make huge statements on that basis anyway. The results were sort of roughly the same, but you could see the impact of introduction of TAVR on numbers for aortic valve procedures in general went up. So went up 7% I think in the surgical group, which hadn't happened for a while, and went up many more fold in the TAVR group, as you would expect. And the risk shift that you would expect also occurred, so that more high-risk patients were showing up in the TAVR part of the registry than in the SAVR part, and the average risk went down in the surgical part, and was hard to say it was going up since it was new, but was higher in the TAVR part.
It's hard to say why there were 7% more SAVR patients than during the course of the study, but one would think that if you're studying these patients more closely with a team-based analysis, are you finding more patients? Is that one reason why the SAVR numbers are going up?
Absolutely. The team-based thing has something to do with it. The fact that the introduction of TAVR made people much more aware that there might be options other than surgery for patients that they had been not treating because they didn't want them to have surgery. And inevitably, if you start bringing those people through the system, there are going to be some who are just fine for surgery and should have had it before.
Right.
But there are going to be many more who are much better treated with TAVR. So there's a rising tide that raises both boats in this case.
Your study yielded some interesting information on the evolution of TAVR in New York over that period of time. What do you think is happening now? You haven't looked at the data, but do you think this is still continuing, that we're still seeing more and more people who are paying attention to the idea that there are options for these patients?
Oh, definitely. It's dangerous probably to speculate on what the next round will show, but it's hard to imagine it won't show a continuation of the same trend. Obviously higher volumes of TAVR patients in more hands, and the risk profile will continue to shift. I don't know whether the TAVR risk profile as an average or a median will go up much more, because they'll be taking in patients who are a little lower risk, but they'll be all coming out of the pool of SAVR patients and decreasing the overall risk in that group. In fact, I think one of the challenges facing TAVR that I've spoken about several times going forward is that we'll be redrawing the risk profile in surgery, shifted way over to the low risk left end of the curve, because all the rest of them will be in TAVR. So TAVR will be taking care of all the high risk patients, intermediate risk, and some chunk of low risk, and the surgeons will be operating on, for the most part, the lowest risk patients.
Now, you mentioned the low risk, and here at ACC 16 you participated in a debate on TAVR for low risk patients. Why not? Or hold your horses. Where are you along in that line?
Well, obviously they assigned me the hold your horses part of it. I have a more balanced view than I might have betrayed in a debate format. I was actually in favor of an all-comers trial 5-6 years ago when we designed Partner 2. But I was a voice crying in the wilderness. Nobody else had the slightest interest in doing an all-comers trial. And I think part of my reasoning then was that was the time to do it, and it would have been the starkest comparison of the new technique versus the old technique. But I think there was a lot of concern that TAVR wasn't ready for that. I don't know whether they were right, but now it's clear, I think, from our experience and what you see in registries and S3 and so on, that TAVR does very well in what we're calling intermediate risk, and how you actually define that in terms of proportions of the surgically treated population is still debated. But I think it's going to be hard to compete with TAVR pretty far down the risk spectrum, and that only the youngest, lowest risk patients will continue to be treated preferentially with TAVR, with surgery, and it looks like there will be 2 low-risk trials going on.
Yeah, that's what I was just going to ask.
I must say now, looking ahead, the unexpected criticism of Partner 2 that I got nonstop yesterday was, this wasn't intermediate risk, this was high risk. Well, when we designed it, it sure felt like intermediate risk, and it seemed like, there was no appetite for low risk then. They almost didn't want to do it. It sure seemed like, and I have now when these low risk trials come out, I bet they're going to say, this wasn't low risk, this is intermediate risk.
It was kind of funny because in the paper that was published simultaneously, your paper refers to intermediate risk, and of course the editorial comment refers to them as high risk, and it's like, did they read the paper? But that's the issue that everybody is talking about.
Yes, and of course I've had to answer the question 100 times, but I think the proof, to my mind, is that, as I said yesterday, however we, put the dart in the board when we planned the trial, the proof is there in that the surgical arm mortality was half of what it was in Partner 1, and the average risk was about half. So we doubled the sort of chunk of patients who were available for treatment by TAVR. So we definitely increased the eligibility pool and cut the mortality in half. And that's not because surgeons got better in 5 years. That's a mature technology. So it's a pretty good argument that it was, if not intermediate risk, lower risk.
Well, this is a great paper, by the way, in JACC Intervention, so I want to make sure that you check that out. It is in the March 2016 issue of JACC Interventions for Cardiol Source World News. I'm Executive Editor Rick McGuire.